like to move on to the second speaker. The second speaker is Dr. Hayato Tada, who is an assistant professor of Department of Cardiovascular Medicine, Graduate School of Medical Sciences, Kanazawa University. He has an over 20-year career in preventive cardiology and human genetics. His research focuses on incorporating genetics into risk assessment and clinical practice, especially in patients with hypercholesterolemia. And the title of his speech is Genetic Testing for FH, Current Status and Future Prospects. Dr. Tada, please.
Thank you very much for your kind introduction, Professor Shiba. This is Dr. Tada from Kanazawa University, Japan. I'd like to talk about the personalized medicine for the patients with FH. So now I'm trying to upload my presentation. And can you see my slide?
Yes.
Yes.
Okay, good. So this is the contents of my talk today. So first of all, I'd like to start my talk by the topic of homozygous FH and heterozygous FH in Japan. As you know, HoFH, homozygous FH, is characterized by severe cutaneous and tendon xanthomas associated with extreme elevation of LDL cholesterol. This is a picture of our patient when he was 31 years old. And this is his family tree. We can see that there are many relatives whose LDL cholesterol levels were very high and died because of cardiac disease at young ages. We understand that LDL cholesterol is the primary cause of cardiac disease by just looking at this family tree. In addition, we learned that his coronary artery disease was very severe at the initial assessment when he was 31 years old. However, we also learned that his coronary atherosclerosis were almost unchanged for decades, according to the intensive LDL cholesterol lowering therapies. And this is his actual clinical course over the years. He has long been treated with lipoprotein apheresis twice a week, and several medications has been introduced, including lomitapide and evinacumab, that could reduce the frequency of lipoprotein apheresis to once in a month. And now he is 76 years old and still alive. This is our important case who provided us many useful information about homozygous FH. And in Japan, we have a unique system of treatment for patients with intractable diseases, including HoFH. This is funded by national government, and medical costs for patients with homozygous FH are mostly covered by the government, while clinical data are being collected. Today, we would like to provide national data of HoFH in Japan. We could use data of a total number of 201 homozygous FH patients in Japan. This is a histogram of ages of their diagnosis. We can see that they are mostly frequently diagnosed as homozygous FH at 0 year, which is quite ideal. However, there are many patients who are diagnosed as homozygous FH after 30 years, as the case I presented at the beginning of my presentation. And second, we can see that patients with homozygous FH were intensively treated using medications that were available at that time in 2019, including PCSK9 inhibitor and lipoprotein apheresis. However, we also learned that their LDL cholesterol levels were not adequately lowered. In fact, LDL cholesterol level before treatment was around 400 milligram, and it reduced to around 150 milligram. So in summary, we learned that the median age of diagnosis of homozygous FH in Japan was 27 years, and that as much as 70% of the patients had coronary artery disease. In addition, LDL cholesterol control was inadequate. So we understand that we need to identify patients with homozygous FH earlier and should treat them more intensively using newer agents. And let me share our case with you. This is a boy who were referred to our hospital at the age of 1. The initial LDL cholesterol level was around 800 milligram. His LDL cholesterol level was reduced with LDL lowering therapies, including lipoprotein apheresis, lomitopide, and evinacumab. Now his LDL cholesterol has been well controlled below 100 milligram, and his carotid artery plaque appeared to be mildly regressed. And now I'd like to move on to the heterozygous FH. So first of all, I believe that we need to identify patients with FH more often based on the estimation among the general population as well as the patients with ischemic heart disease. When we think about the diagnostic rates of heterozygous FH in the world, it has been described as less than 1% in Japan at 10 years ago. However, I estimate that we are diagnosing heterozygous FH around 40% based on the number of patients with heterozygous FH and the number of population at our area called Hokuriku area in Japan. However, it was unclear until recently what is the actual diagnostic rate of heterozygous FH in Japan. In this regard, we had a chance to investigate this issue using the National Receipt Database. We found that the prevalence of heterozygous FH among general population was 1 in 344, and we also found that only 2.6% of the patients with heterozygous FH were actually diagnosed as FH. So we understand that we need to identify patients with heterozygous FH more and more. So now I will move on to the FH guideline in Japan. As Dr. Ogura mentioned, we have updated the FH guideline in Japan, where the cutoff points were revised in the Achilles tendon thickness, so that the sensitivity of diagnosis will be increased. In addition, the assessments by the ultrasound is now also accepted as a new modality. In addition, genetic testing is now being covered by the National Health Insurance, so the presence of pathogenic genetic variant can be used as FH diagnosis. The next important question of FH would be when to treat FH patients. To answer this important question, I'd like to share with you our important clinical data of heterozygous FH. The upper panel shows the coronary plaque and the lower panel shows the carotid plaque. We can see that coronary plaque and the carotid plaque appear to start to develop at around 20 years in male and 30 years in female. So the treatment should be started before those ages. In addition, we also found that patients with FH who started to be treated before the age of 20 years had no cardiovascular disease events, probably because of low LDL cholesterol accumulation over the years. So now we move on to the how to identify FH patients early stage. I think there are two major ways of identifying patients with FH. The first approach is the cascade screening. This is the largest family tree we experienced, and we could identify many younger patients based on the identification of the proband. And the second approach could be universal screening. This is a scheme of universal screening of FH implemented in Kagawa Prefecture in Japan. Children at Kagawa Prefecture are screened at the age of 9 or 10 years at elementary schools. And if their LDL cholesterol is greater than 140, then they are referred to the local clinics or for further checkups. And finally, they are referred to the designated hospitals where genetic testing can be performed if they are actually suspected as FH. And this scheme has been shown as quite useful, identifying hundreds of pediatric FH patients as well as their parents as FH in Kagawa area. And 2 years ago, one of the lawmakers of Japan advocated that this is a very good system that can save a lot of young lives in Japan, and that this should be implemented in a nationwide manner. Ministers in charge refused to do so at that time for several reasons. However, we are still working very hard to expand this scheme all across Japan. And now I'd like to move on to the next topic of genetic testing and imaging. First of all, let me remind you that the presence of pathogenic variant as FH was associated with increased risk for coronary artery disease, suggesting that it can be used as a biomarker for risk assessment. In addition to the presence of pathogenic variant, the type of genetic variant also matters. In this study, we investigated if the type of the pathogenic variant was associated with LDL cholesterol among patients with FH. And we found that LDL cholesterol value caused by protein truncated variants was significantly higher than that by the missense variants. Furthermore, we found that patients with FH caused by protein truncating variation had worse clinical outcomes compared with those caused by the missense variants, probably due to the difference of LDL cholesterol accumulation over the years. So I proposed the personalized medicine for patients with hyper LDL cholesterol. When we encounter a patient with hyper LDL cholesterol, then we need to see if he or she is FH, including genetic testing. And if he or she has pathogenic variant, especially protein truncating variation, then they should be treated more intensively. In addition to these observational studies, we conducted a randomized trial named GENTLE-FH trial to see if genetic counseling based on the genetic testing of FH will improve LDL cholesterol level as well as patient satisfaction. we can see that genetic counseling could actually reduce their LDL cholesterol level by 13 milligrams, and this difference was attenuated after the intervention to the controls as well. When we divided the patients into two groups based on the presence of pathogenic variant of FH, and we found that LDL cholesterol reductions were observed only in patients with pathogenic variant by adding LDL cholesterol lowering medications according to the counseling. And we found no difference in satisfaction. So based on these results, we are very happy to tell you that genetic testing for as many as 200 genetic diseases are now covered by the National Health Insurance in Japan, including FH. So I'd like to explain how imaging would also be helpful to risk stratification in FH patients. In this slide, I'm showing that patients with FH with severe coronary artery calcium (CSC) had worse clinical outcomes. On the other hand, patients without coronary artery calcium had quite better prognosis. In addition, we found that coronary plaque and the carotid plaque were correlated, and that patients with more plaque burden assessed by both modality had worse clinical outcomes. And next, I want to focus on clinical variables. In 2016, IAS, International Atherosclerosis Society, has published an interesting paper clarifying the definition of severe FH. It is a very simple criteria where FH patients are classified according to LDL cholesterol level and other clinical variables. And it has been shown that this simple criteria works quite well in risk stratification in FH patients. And in our data, we also checked if LDL cholesterol year score was different between severe FH and non-severe FH. And we found that severe FH had a larger burden of LDL cholesterol accumulation. And as a result, we found that severe FH had worse prognosis compared with non-severe FH. And importantly, even among severe FH patients, those who attained LDL cholesterol treatment target goal had better prognosis compared with those who did not attain LDL cholesterol treatment target, suggesting that patients with severe FH patient should be treated more intensively. So finally, I'd like to present our approach based on these findings. So first of all, we classify patients between primary prevention and secondary prevention. In the patients with secondary prevention, we consider super aggressive LDL cholesterol lowering, targeting at LDL cholesterol less than 55. In addition, we divide the patients of primary prevention setting according to the presence of additional risk factor, and we treat them more aggressively if they have any of these risk factors. And this is all my presentation. Thank you for your attention.
Thank you, Dr. Tada, for your great presentation. And now this paper is open for discussion. If you have any questions or comments, and so if you have any question or comments, please raise your hands or or using chat. And Dr. Tada mentioned, Dr. Ogura, do you change the LDL treatment targets for different variants?
Thank you for your very good question. So the very simple answer is yes. When I encounter a patient with a protein truncating variation, I usually set a very intensive treatment target compared with other variants, especially with patients without any variants. So I try to persuade the patients with a very bad variant to intensify medical treatments, especially at the timing of the genetic counseling before the genetic testing. So I believe that this is a kind of companion diagnosis. In the case, it's very similar with the treatments for the patients with the any type of cancer. It's like a breast cancer. So in the case with a very bad variant, I try to persuade the patients to treat them more intensively.
Thank you.
And you mentioned about mass screening in Kagawa Prefecture, but only in Kagawa Prefecture and not all over Japan. And what do you think is the hurdle to expand the activity?
Yeah, it's a very good point. So I think there are several hurdles to overcome. The first is the cost effectiveness. So any of the lawmakers need to understand that any approach is beneficial in terms of the cost, because any procedure need the cost. So lawmakers should explain how effective, how useful in any ways. So I think we need to clarify how cost effective this approach is. And the second hurdle, I think, is the blood sampling. So some of the parents are concerned about the blood sampling using the needles. So I hope in some days that we have some strategy to monitor or to check the serum LDL cholesterol level using the non-invasive manner, using the optical coherence or any other. I'm not fully sure, but if we have some strategy calculating or speculating the LDL cholesterol value with non-invasive manner, I think it's acceptable for all the children.
Thank you. And another question from Dr. Mutas. What do you think of the importance to screen premarital couples for FH, searching for HeFH?
It's also a very important point. So sometimes we are encountering such patients with heterozygous FH as well as sometimes homozygous FH. In the case with the couples who both of the couples have heterozygous FH, but it's very rare. In the case of heterozygous FH, I think we should persuade the patient and the parents, couples, that we have a variety of strategies to reduce LDL cholesterol. Even the baby has the heterozygous FH, and typically the treatment starting point, starting age should be around 8 to 10 years, and it does not affect any of the growth in the children, and it can save their lives. completely. So I think the explanation of the nature of the heterozygous FH and the early screening and early treatment, importance of early treatment and early screening is very vital for the couples who have the heterozygous FH.
Okay, thank you very much, Dr. Tada.